Hi, everybody. My name is Tom Fusillo. I am a second-year internal medicine resident, and in this video, I wanted to talk about community-acquired pneumonia. CAP, or community-acquired pneumonia, is something that every internal medicine physician, many other physicians for that matter, should know how to work up and treat. It's common. We see it inpatient and outpatient. So with that, I hope you will enjoy this and find it useful.
All right, let's talk about community-acquired pneumonia. So first things first is we need to clarify the actual types of pneumonia because this can confuse people sometimes. So CAP, or community-acquired pneumonia, is defined as a pneumonia that develops outside of a hospital or healthcare setting. And so this flow chart here that I have, I differentiated between the ones that you might get confused with. So CAP is here on the left, and I put aspiration under this just to make the point that previously aspiration pneumonia was kind of thought to be its own entity with different bacterial etiologies, but now it's thought of as just a type of CAP. And it's treated the same way, actually. But besides CAP, we have HAP, hospital-acquired pneumonia, which is defined as a pneumonia that develops after 48 hours of being in the hospital. VAP, which is ventilator-associated pneumonia that develops after 48 hours of being on a ventilator. And so this is a new subtype here, HCAP, which is healthcare-acquired pneumonia. This is pneumonia that develops in a non-hospital setting, like a nursing home, rehab facility, that type of thing. Just to make the point again that aspiration pneumonia can fall under any of these, but is typically treated the same as the one it falls under. It's not its own entity anymore. Talking about some of the epidemiology with CAP, the incidence increases with age. The overall incidence is about 250 per 100,000 adults. But like I said, incidence increases with age, which is why the impressive stat here is that in patients that are 80 years old or older, the rate is now over 16,000 per 100,000 adults. So this really is a major deal for some of our elderly patients here. It has a hospitalization rate of about 2% in patients that are older than 65 years old. So it's a frequent cause for admission. And the 30-day mortality rate is actually about 6% in hospitalized patients. So that's not an insignificant number when you think about it. So when we talk about the pathophysiology of CAP, of pneumonia in general, how does this actually happen? How do we get pneumonia? Well, first things first is that a pathogen is introduced to the alveoli, right? And so this can happen in a few ways. Inhalation, although that's less common, and more commonly we think of it as microaspiration. Right, so what is microaspiration? That's secretions, very small volume of secretions going from your mouth, from up the esophagus, down the windpipe, okay, down the trachea into the lungs, and it gets into those deep airways, okay? So now you have an outside pathogen deep in the lungs where it shouldn't be. And so once you have that, you get this local inflammatory response. You have macrophages in the alveoli, and so those kind of react with this. So we see here the pathogen comes down into the alveolar space. It replicates and multiplies bacteria, and then you start to get that macrophage activation. And after that, it's kind of a circular type self-fulfilling prophecy. You see a ton of inflammatory cytokines released, things like IL-6, and you have your neutrophils extravasate here. They eat up bacteria, and so you get this tremendous inflammatory process. And what happens here, after you get all these dumping of cells and bacteria, this is actually what is producing a lot of the phlegm and the wet cough that you might see in somebody with pneumonia. And so the worst case scenario really is if you get kind of translocation of the pathogen from the alveoli into the blood flow, into the systemic circulation, because then you have a bacteremia type infection, and that can spread everywhere. So let's talk about some infectious etiologies. So starting with bacteria, we split bacteria into what we call typical and atypical, which is, as it kind of sounds, the typical are much more common pathogens. Atypical we don't see as often. So starting with typical, strep pneumo number one. We see this a lot. H. flu or Haemophilus influenza, Staph aureus, which includes MRSA, which is methicillin resistant, as well as MSSA, methicillin sensitive. Pseudomonas, a little less common, but still considered typical, and then Klebsiella pneumonia as well. On the atypical side, we have Mycoplasma pneumonia, Chlamydia pneumoniae, and Legionella. And the atypicals are sometimes called walking pneumonia as a colloquial, especially Mycoplasma, sometimes called walking pneumonia, just because it isn't always as serious. You can see these people, quote unquote, walking around on the street, and that's how it gets its name. Two of the pathogens that we really always have to think about, especially in the hospital, is MRSA, MRSA, methicillin-resistant Staph aureus, and Pseudomonas. We care about these a lot because they can be very infectious and they can cause devastating pneumonia, bacteremia, and sepsis. So when do we actually want to treat for these preventatively? Well, we look at the risk factors. So the first one is prior infection. So obviously, if you have a patient and you know that they've had MRSA or Pseudomonas in the past, not just in the lungs, bacteremia, soft tissue infection sometimes, and you have that data, you're going to want to treat for this now, right? Because that would be a really bad thing to miss. The next is, have they had recent IV antibiotics? And recent usually means in the past 3 months. So the past 90 days, if they've had IV antibiotics, regardless of what they were, that can be a risk factor for developing MRSA or Pseudomonas because these are more resistant pathogens. On the MRSA side, recent viral illness is a risk factor. It's often taught in medical school that if you have an influenza pneumonia, what can follow after that is a bacterial pneumonia, and that can often be MRSA. So that's something we have to keep an eye out for. Cavitary infiltrates on chest x-ray or CT chest can be concerning for MRSA, and related to that is empyema. So both of these things really have a pus and fluid picture, which a lot of times we associate with MRSA. And then finally, to finish up the MRSA risk factors, end-stage renal disease could be a risk factor here. On the Pseudomonas side, bronchiectasis and frequent COPD exacerbations. Usually the relationship between that is because when you have a COPD exacerbation, you're often given a lot of antibiotics and steroids, which can predispose you to these pathogens. Talk a little bit about viral pathogens here in CAP. So obviously influenza A and B, really important one, cannot miss. Fortunately now it's very easy to test for in the inpatient and outpatient setting, a lot of rapid influenza tests. RSV is making a resurgence right now as I record this video, very seasonal. Coronavirus, of course, not just COVID-19, the SARS-CoV-19, but there's also just a regular seasonal coronavirus that has been around forever before COVID-19 that in many cases is the common cold, but obviously can cause a more serious infection like a pneumonia. Rhinovirus, which is the common cold, really, can also cause a pneumonia, especially in your elderly patients. Adenovirus, and then metapneumovirus or human metapneumovirus. The big thing to remember here is that a lot of these will have seasonal trends. So we look at this graph. This is showing admissions of flu. This is a flu graph by week. So as we get later in the year into November, December, really December is when you start to see that spike and it comes down. So one thing to think about when you look at this is, when should you get your flu shot? A lot of people will get it as soon as it comes out, and sometimes that's as early as August. But if we're really not getting flu coming around until November, December, some would say might be worthwhile waiting a little bit later, mostly closer to like October, early November, to get that flu shot so you get maximum protection. Because, some data shows that the flu shot really only gives you 4 to 6 to 8 weeks of protection before it wanes. And the important thing with viral is sometimes these viral pneumonias can be really nasty. They can be really bad. Why is that? Because that single virus is so small, it gets you down to the deepest part of the lungs, the deepest airways, which can be really hard to expel with a cough. Lastly is fungal. So when we think of fungal, PJP, which is Pneumocystis jirovecii, Aspergillosis, Cryptococcus, and Cocci. What we're looking down here on the left is an Aspergillus on smear. And then this over here is a heat map of Cocci infection. And we see really known for being down in the southwest of San Joaquin Valley. When I was in medical school, I did a rotation in Bakersfield, which is right in here, this hottest spot. And we saw a ton of this, not just pneumonia, but soft tissue infections, meningitis. It really is a nasty fungal infection. But the important thing to know with these fungal infections and fungal pneumonias, it's really much more common in immunocompromised patients. And just an important thing to remember for exams, PJP specifically is thought of as an AIDS-defining illness. So let's talk about the diagnosis and the diagnostic process. So with clinical evaluation, first things first, always look at the vital signs, right? When we're looking at those, remembering our SIRS criteria, temperature, heart rate, what's the respiratory rate, and the white blood cell count, right? So SIRS, technically, if you have 2 or more of these, you're SIRS positive, but even if somebody has 1 and some other signs on exam, that's going to raise red flags, right? Because this is a whole picture. We're not looking at individual pieces. On physical exam, the most important thing in the physical exam, in just about any sort of situation, if you ask me, but especially pneumonia, is just the look test. Look at this patient. Do they look comfortable? Do they look like they're having trouble breathing? Do they look anxious because of their breathing? Are they using what we call accessory muscles? So those are the muscles in the neck and the lats. Are they using those muscles to help them breathe? If so, that's much more concerning than the patient who you think might have pneumonia, but they're sitting there, they're breathing comfortably, they're not worried, they're talking to you in full sentences without having any trouble, right? So really trust your judgment on the look test here. Lymphadenopathy can be helpful, especially, in the neck lymph nodes, can kind of hint at an infection brewing. And of course, listen to the chest, right? Listening to their lungs. Are you hearing crackles, wheezing, full breath sounds, reduced breath sounds, that sort of thing? For exams in medical school and USMLE type thing, remember, these are the pulmonary tests that they test you on, but we really never actually use in practice. Egophony, which is if you have the patient say E, and then you hear A through the stethoscope. Whispered pectoriloquy, have the patient whisper something, and then it sounds like it's in normal volume when you're listening to them through the stethoscope. Bronchophony, the patient says a word, and it sounds much louder in the stethoscope. You can percuss to see if you hear a density, and then they might have decreased diaphragmatic excursion with percussion. Again, we really never do these in practice because we can just listen and then look at a chest x-ray, but these are often tested on anyway. I also put volume status in here because one of the great mimickers of pneumonia can be heart failure, right? And pulmonary edema. And one of the things that can help you differentiate is if they have a bunch of edema in their ankles and they're swollen or they're anasarctic, maybe it's not a pneumonia, maybe it's more of a heart failure exacerbation. I mean, it could be both. It definitely could be both, but this could be a helpful sign. Laboratory-wise, CBC with diff, including the diff here, because remember, elevated white blood cell count, but also looking at, is this lymphocytic or neutrophilic predominant on that elevated WBC? We look at a BMP to see if there's any electrolyte abnormalities, especially if the patient has been having poor intake, they've been feeling sick, they're not drinking as much, they're not eating as much. Are their electrolytes in line? And then the last one that's a bit of area of controversy is the procalcitonin, the procal. So we look at a study here, this is a big study, Self and colleagues, which the relationship between procal and pneumonia etiology, viral versus atypical bacteria or typical bacteria. Those are the ones we talked about earlier in the lecture. And what they found was that the median procal was about 0.09. The units here are nanograms per ml in viral pathogens versus 0.2 in atypical or 2.5 in typical. So what the point of this is, they saw that there are some differences in the procal based on what the infectious etiology is. Now, the atypical to viral was not significant. It was 0.05 as the p-value, so not significant. But comparing procalcitonin levels in typical bacterial cap infections to viral was significant. P-value was less than 0.01. So that's what this chart here is showing. So viral versus atypical, there was no significant difference. But if we're comparing typical bacteria to viral, there is a significant difference where typical is usually has a higher procalcitonin. The important thing to know, I would agree with this in practice as well as the IDSA says, the procalcitonin alone should not be used to determine initial treatment. In other words, if you have a low procalcitonin, you should not see that and say, we don't need to give antibiotics because it can't be a bacterial infection because the procal is low. It has to be viral. No. Look at the patient, look at the full picture. You can use the procal to help you justify your decision, but you need to use other variables as well to determine how you're going to treat this patient. And additionally, there's some data out there that says that procal can actually help trend improvement. It might be better in actually trending improvement rather than using it up front to determine how to treat. Talking about imaging, chest x-ray is the mainstay, right? So when we look at these chest x-rays here, when we think of typical versus atypical, typically we see this very definitive lobar pneumonia here. So we have a right lower lobe pneumonia here. You can see the haziness, opacity, right here compared to the rest of the lung fields, which look very clear. You have sharp angles, and you just have this haziness down here. Same here, we have a right middle lobe pneumonia, very definitive borders. But on the other hand, and this one down here, this is an interstitial pneumonia, right? There's not really a lobar geography. It's just all over the place when you look at this coming out from the hilum. So this would be an interstitial pneumonia. You can use a non-contrast CT, but really you don't need it that often. The times where it might be useful is, well, if the patient's just not getting better and we need to get a better picture, is there something we're missing here? But also if there's an empyema, an abscess, or an effusion to really assess what the borders of that are. So this is what a pneumonia CT chest would look like, more of an interstitial geography distribution here because it's just everywhere, right? It's not just one lobe. Another important thing to remember is it can take several weeks to actually resolve radiographically. What I mean by that is, let's say your patient comes in, you take this chest x-ray up here, you treat them, they're feeling better. If you take another chest x-ray a week after treatment, it might look the same, but they're feeling great. Does that mean you have to keep treating them and giving them more antibiotics? The answer is no. Remember, this is an inflammatory process. So that lung parenchyma is really going to take time to heal and to return to normal. So don't expect the chest x-ray to resolve right after you finish treating and the patient is feeling better. An important part in CAP is seeing if we can figure out what the etiology is behind the infection. It's very difficult. A lot of studies show that actually the etiology is only determined in less than 10% of cases. So we really don't find out what the bug is that's causing this very often. And because of that, we need to think about the cost versus the benefit. A lot of these tests, a lot of these cultures can be pretty expensive. And if we are going to get an answer just 10% of the time, how worth it is it? But let's talk about some of the ways you can. The first is a sputum gland stain in culture. It has a less than 50% yield, so pretty poor yield. And from personal experience, I almost never really order these in the hospital, honestly, because most of the time it'll come back as contaminated or normal oral flora. And that's because patients think of this, oh, it's just spit in a cup, right? No, this is not a spit sample. It should be deep sputum. So it has to come from deep in the lungs. And that can be hard to get. And it's not the patient's fault. That can be hard to get up sometimes. When I'm ordering these, sometimes it's only really useful if you have an intubated patient, right? Because then you can actually use the inline suction in the endotracheal tube to go down there and suction out a deep sputum. The second is blood cultures. So does every patient with community-acquired pneumonia really need to have blood cultures drawn? The answer is absolutely not. If you're outpatient, probably almost never would need blood cultures. If you're inpatient, then you have to think about it, right? What are their risk factors? How bad are they? How are they breathing? How do they look? How sick do they look? Okay, if this is a sicker patient or they have risk factors, blood cultures could be indicated because you don't want to miss a bloodstream infection. Again, yield here is fairly low, 5 to 15%. Urine antigens, so there's Legionella and pneumococcal antigens. Again, these can be used in patients with risk factors or who may be a little sicker. We really need to figure out what's going on here because treatment's not working. Next, there are serologies. So this is looking for antibodies specific to certain pathogens, IgM specifically, because those are your acute antibodies. The one I see used the most here is Mycoplasma pneumonia. But again, this can be tough to be useful because a lot of times these serologies have to be sent out to outside labs and they can take days to come back. By the time they come back, it's the patient, you've either been treating them and it works or they've decompensated by now. So a lot of times it's not very helpful. And then we have PCR. So this is most useful for your viral pathogens. And over here, what I included was what a sample report would look like. You might hear this called as like a biofire test, which is like one of the brand names. So you get a good amount of viral etiologies on these reports. And so this report, it shows you not detected for everything, but positive for COVID. So this would be like what a sample report for these are. And it looks for a lot of things: influenza, COVID, both COVID-19 and the seasonal, adenovirus, metapneumo. So these can be very helpful, both inpatient and outpatient. Let's talk a little bit about treatment. The biggest thing when treating community-acquired pneumonia is, does this patient need to be admitted to the hospital or can you treat them outpatient? And really this depends on the clinical picture and what is their risk for having a bad outcome. Well, we use scoring tools for these. The two main ones we used are the CURB-65 score and the Pneumonia Severity Index, or the PSI. So let's start with the CURB-65. First of all, you can only use this on patients who are 65 or older, right? That's why the 65 is in there. They have to be over age 65. Otherwise, this really is not a great scoring tool. And then the CURB is actually a mnemonic. So C stands for confusion, U is the urea, respiratory rate, blood pressure. And you get a point for each of these, and then you can risk stratify yourself. And so here you can see if they have 0 to 1 point, this can probably be treated outpatient. Now, in the middle ground, you can consider either one. Maybe admit, maybe stay outpatient, but you really should keep an eye on them. And then over 2, which is 3 to 5, this should be a hospital-managed pneumonia. A newer scoring system, which is the PSI, which we use a little more often now. This can be used at any age. You get 1 point per age. Differentiates between the sexes, things like nursing home, what are their comorbidities, their vital signs and physical exam findings, and then laboratories and imaging. So it includes a lot more variables in the CURB-65, and then it has greater risk stratification classes, right? So they have classes 1 through 5, and this is where you can help decide, should this be outpatient or inpatient management? I'm going to close out with how do we actually treat this, because this is the big question. So I made this flowchart to try and simplify it. So here you have a community-acquired pneumonia. We'll start at the left. Let's say it's viral. You know it's viral, or you're very suspicious. Well, if you think it's flu, give them Tamiflu, oseltamivir. If you think it's flu and bacteria, remember what we said earlier. Viral illness, viral pneumonia is often followed by MRSA, MRSA, right? So that's why you need to add vanc, oral linezolid, and a third-generation cephalosporin. So you treat the viral cause and the bacterial cause at the same time, and the bacterial cause should include the possibility of MRSA. And by the way, everything in this chart is IDSA guidelines, so this is not just what I do, this is what the IDSA recommends. So we come over here, and you have a bacterial cap. Remember, we just said next step is decide, should we treat them inpatient or outpatient? So let's go to the outpatient. After you know you're going to treat them outpatient, you decide, do they have comorbidities, or have they had recent antibiotics? Or are they pretty healthy generally? They haven't had recent antibiotics. So let's say you have a healthy patient, they haven't had antibiotics recently. The recommendation is amoxicillin or doxycycline or macrolide, so single agent use. I starred macrolide. Why? Because do not use a macrolide if local resistance is over 25%. And for the record, almost everywhere in the US, it is over 25%. So this should not be used as monotherapy, at least in the US. Doxycycline or amoxicillin, you can use as monotherapy in these patients. If this patient has some comorbidities, what does that mean? Things like diabetes, renal disease, heart disease, lung disease, they use alcohol, they're a smoker. That would be a comorbidity. Or recent antibiotics. What we're going to do, you're going to use a respiratory fluoroquinolone, which is either levofloxacin or moxifloxacin. Or you can do a beta-lactam and doxycycline or a macrolide. In other words, you can use a beta-lactam and doxy, or a beta-lactam and a macrolide like azithromycin. And in many cases, the beta-lactam here is augmenting. So that's amoxicillin and clavulanic acid. All right, so you have a bacterial cap and you want to treat them inpatient. What are we going to use? A beta-lactam and a macrolide, or a respiratory quinolone alone. I can tell you most of the times what I'll use and what my colleagues will use is ceftriaxone and azithromycin. So that's your beta-lactam and macrolide, and we use those both IV in the hospital. Respiratory quinolone, you could also do, which usually would be levofloxacin, IV in the hospital. And then finally, like those special cases, the MRSA and the Pseudomonas, because those are ones we don't want to miss. Pseudomonas, you're going to add an anti-pseudomonal beta-lactam and azithromycin. So what are your anti-pseudomonal beta-lactams? Those are piperacillin tazobactam, or Piptazo, brand name of Zosyn, or cefepime. I believe the brand is Maxipime for that. If you're concerned about MRSA, similar to what we said over here, you're thinking adding vancomycin or linezolid. The difference between these two really is that linezolid has a PO version, so you can give it orally if you need to, if you want to finish a course outpatient, for example. I'm going to end by talking a little bit about steroids, because there's a recent New England Journal of Medicine study that showed some benefit in steroids and community-acquired pneumonia. So the Queen and colleagues looked at hydrocortisone in patients admitted to the ICU with community-acquired pneumonia. So this is only for patients in the ICU. That was the cohort that was studied. This does not apply to outpatients. It does not apply to patients in the ED. It does not apply to patients on the floors. This is ICU level patients with CAP. What they looked at was hydrocortisone infusion, so a continuous infusion of 200 milligrams a day for 4 to 7 days, followed by a taper. And they looked at 28-day mortality. At 28 days, mortality was 6.2% in the hydrocortisone group versus 11.9% in the placebo. So this was a significant difference. In other words, the patients who received hydrocortisone had a significantly lower risk of mortality at 28 days. They also looked at intubation. Intubation occurred in 18% that were in the hydrocortisone group versus almost 30% in the placebo group. That was also significant. So what we're looking here at the graph is as time goes on, what are the chances of being intubated, the placebo line above the hydrocortisone line the whole way. The study was even halted early, right? So their results were so convincing that they stopped the study. Another thing they looked at that I thought was interesting was they looked at what was the chance of you being put on vasopressors, depending on what your group you're in. And once again, the placebo group had a higher incidence of being put on vasopressors than the hydrocortisone group. So really convincing data to consider in your ICU level patients to give them hydrocortisone steroid.
So I hope that was a helpful review on CAP and community-acquired pneumonia. And I hope you'll come back and watch another video in the future.